Okay, great. So good morning, everyone, and good evening as well. Um, my name is Purba Chatterjee, and I'm the Associate Director for Global Health Equity. I'm based in the UCSF Department of OBGYN, as well as the Institute for Global Health Sciences. And on behalf of the UCSF Institute for Global Health Sciences, I'm very pleased to welcome all of you to this inaugural session of IGHS's Global Partner Spotlight Seminar Series. With this new seminar series, we are actually trying to showcase the impactful work of our partners around the world, offering a window into their innovations, highlighting their priorities, and sharing some challenges our partners encounter in their local contexts. Through these sessions, we hope to foster deeper understanding, collaboration, and shared learning across borders. And we are honored to begin this series with a talk on antimicrobial resistance in Africa by our esteemed guest speaker, Dr. Samuel Kariuki. Dr. Kariuki brings a wealth of experience and insight from his leadership roles at DNDi and the Kenya Medical Research Institute. We look forward to an engaging and thought-provoking discussion on this topic. And Karibu Sana, Dr. Kariuki, and I know that you actually visited UCSF and IGHS a few years ago. So it's really great that you're launching this new Global Partner Spotlight Seminar Series for us. Thank you. And over to you.
Thank you very much, Pamba. I'm most delighted to be able to be here and present to you and share some of the work we've been doing on antimicrobial resistance mainly at the Kenya Medical Research Institute. I just joined DNDi as the continental lead about 2 years ago, but I still retain my research position at KEMRI. So hence, of course, this very, very close collaboration. Some of you may be aware that actually KEMRI was a founding partner of DNDi. So I'm just seconded to head that institution in that respect. So for today, again, this is a very, very important forum, in my opinion, to be able to disseminate some of the work we do here in Africa that definitely has a global perspective, and hopefully at the end of this, be able to provoke some discussions around areas that we could work together to make the world a better place for everyone. So this is my title. We've been doing some work relating mainly to deploying One Health approaches to manage antimicrobial resistance. And we'll be looking at some of the challenges we have in Kenya and the region, as well as opportunities that we could work around. So again, just to begin with this quote from Paul Ehrlich, we all know about him, and the work is done on microbiology, that drug resistance follows the drug like a faithful shadow, meaning that as soon as you use any antimicrobial, there will be resistance. What matters really in as far as use of antimicrobials is concerned is how best we can use them, that is, use them prudently to be able to delay this emergence and spread. That is what really matters for this field. And I thought I would start first by looking at and providing a perspective of the AMR crisis and One Health. And we may be privy to some of this information to put this crisis in context and in perspective. If you look at the global impact of COVID-19 to that of AMR, you will find that COVID-19 caused nearly 3.6 million deaths globally, whereas AMR from the Lancet, the Lancet Commission paper, nearly 5 million deaths. And this definitely will be increasing unless we intervene in a way. And all over the world, sometimes data is underestimated, but we know for sure millions are dying from drug-resistant infections. And some of this has been highlighted in media. We know from a lot of studies in Africa and elsewhere, really regarding the danger we find ourselves in, the challenges of antimicrobial resistance everywhere, where we're looking really into an era where we may be talking about post-antibiotic era if we don't look carefully into how we operate within the perspective of control and prevention. An MSc student of mine actually did some studies around the suburbs of Nairobi, and families are trying to egg some living, putting some chickens around the houses so that they earn some money from eggs and so on. And just looking at the surrounding, and she could pick all these packages here. And you don't need to be told what antibiotics they use. You just need to go to the backyard and read for yourselves that even small-scale farmers are into use of antimicrobials for growth promotion of their chickens. Just tells you the extent to which misuse, overuse, and abuse of antimicrobials can go, and how that impacts human health at the end. So why then is this One Health approach in AMR important for us? Because, of course, antimicrobial resistance is truly a global problem. And antimicrobials, as we know them, are used in many settings, be it in human health, in communities, in animal health as well, in aquaculture, in horticulture. And obviously, same molecules that we use in humans will be used in other sectors. And any use, as we learned from Paul Ehrlich, we select for resistance. And we know these bacteria and their genes will cross every geographic or ecological borders without impediment. So we must be aware of this. And in my talk, what I've decided to do is to share with you a couple of examples that are going to provide some information regarding the burden of antimicrobial resistance in Kenya and the region, as well as opportunities that present themselves on how best we could ameliorate this problem. And one of the diseases that are endemic in Kenya and the region is cholera. This is a waterborne disease, oral fecal transmission. And in this country and the region, we see cyclic outbreaks of cholera. And these bacteria often are multi-drug resistant, at least for the last 15 years or so. And some of the major outbreaks occur almost in the cycle of between 7 and 10 years. And you can almost predict that this will repeat themselves that way. And we'll just be wondering what drives these cyclic outbreaks, and that this is going to be part of my talk. And these periods, particularly in between 1980 and the year 2000, we find very, very high case fatality rates. In fact, some of the highest in the world that occurred in our region. And these are periods that are coincided with El Nino effect and the La Nina climate cycles. But more recently, we're seeing also that apart from flooding, for example, that caused major outbreaks between 21 and 2022, we find a lot of cholera now happening even during the drought season, during the dry season. And again, it begs for questions. We know this is a fecal transmitted disease. Why is it persisting even during the dry seasons? So as of January 2023, nearly 5,000 cases of cholera were recorded. And some of these cases apparently didn't just happen in areas that we think are high risk, like the informal settlements and so on. In one particular case, this was a very high profile wedding ceremony. And for some reason, nearly 50 of the guests got admitted to hospital. Very, very high level wedding. Apparently, they had outsourced some juices and I think some salads and so on. And we think that's where the cholera came from. It just tells you that can form a spark at once for a spread of cholera to happen. And we've also seen post-COVID-19 a lot of outbreaks that would definitely be attributed to laxity in the wash habits that people had achieved during that period. And that is also very, very wanting. And I'll point to this article that I contributed to in this platform that we call The Conversation. And this particular article I wrote on why cholera continues to threaten many African countries. And I alluded to the fact that in Africa particularly, we tend to be very reactive to these sporadic outbreaks, but sometimes even epidemics. Once we through with one epidemic, we forget completely that another will come, and we don't take cholera seriously enough. So this is one of the articles that I wrote regarding some of those challenges and what public health needs to do to improve how we deal with outbreaks. And again, one of the major factors that is driving the current pandemic is the issue of antimicrobial resistance. We find multi-drug resistant strains of Vibrio cholera that are causing outbreaks in Kenya and the region, and nearly 60 to 70% of them are also extended spectrum beta-lactamase producing strains. And that puts us a big strain on antimicrobial resources that are required for prevention and control, but also for treatment of patients. And we also hypothesize that this multi-drug resistance ESBL producing phenotype is causing these bacteria to be able to persist much longer in the environment, and therefore obviously provide a reservoir for constant outbreaks that happen. We first observed ESBL producing strains around 2012, and these were patients from refugee camps in the northern part of the country. And then we had a couple of weeks later, and down to 2015, there was widespread outbreaks around the city of Nairobi and going towards the coastal area, and then back towards the Lake Victoria region. And since then, nearly all our Vibrio cholerae isolates are ESBL producing. It's just a matter of 5 to 10 years, and the apparently sensitive strains were completely replaced by multi-drug resistant ones. Just tells you the power of these bugs in terms of evolution within a very, very short space of time. This multi-drug resistance phenotype is driven by genes on a large mobile genetic element, approximately 169 kilobases. It's quite a huge one. And one of the genes that is quite prominent for ESBL producing strains is CTXM15. Same gene that you find in ESBL producing Acinetobacter, Klebsiella, and E. coli as well. Just tells you that these are bugs living in the same ecosystem, and they share between them these very, very large mobile genetic elements containing AMR genes. Again, just telling you, this is a global village for these bugs and their resistance genes. So what we've been doing is that we are utilizing our study. Excuse me. We've been utilizing our. Have I lost my slides? Can you see the slides still?
Yes. Mm-hmm.
Okay. Yeah, we've been utilizing our study site, which is in Mukuru. Mukuru is, I would say, about 15 to 20 kilometers east of Nairobi, where we constantly have been doing studies on enteric infections that are important for the country. And what we found out is that and excuse me, because I think my screen here is misbehaving. Just a moment. Something I've touched, and I'm sorry about that.
No.
I need to check on that. Apologies about that. Yeah. So what we do at Mukuru, which is one of our DSS sites, is that we've been mapping the hotspots for cholera. And this is one of the most densely populated areas on informal settlements east of Nairobi, nearly 150,000 people living in a very, very small area. So we find, of course, that issues around wash and wash infrastructure are really, really strained. And what we did was to investigate exposure to fecal contamination using qualitative analysis that we call sanitation pathways qualitative analysis. And we did this with our colleagues from Emory University. And we investigated a total of 9 possible pathways: floodwaters, household, storage water, soils, food, surface waters. All these built from the fact that we were able to investigate and see through a pilot that most people would have been exposed to this in terms of cholera. And what we found out actually is that the most dominant pathways, and these are really here in relation to the size of the boxes that you see here, constitute many open drains, municipal water, and flood waters as well. And we then, of course, through the articulation of the standing path assessment, asked, of course, through discussions with the Municipal Council and the Ministry of Health, that we introduce oral cholera vaccines for the immediate arrest of transmission of Vibrio cholera in these settings. Why? Because in this setting, we found more than one pathway that was critically important for transmission of cholera. And this is an article that we wrote at that time calling for vaccine rollout to be able to arrest an otherwise outbreak that was going out of control within the suburbs of Nairobi. And our team here is working together with Ministry of Health to deploy oral cholera vaccine. Now, the other example that I want to draw your attention to, and which also for a region in Africa is critically important, is invasive non-typhoidal salmonella strains. Most, nearly 60% of these are multi-drug resistant, and some of them also are tending to be extremely drug resistant, XDR strains. And we've been, again, studying ANTS infections, especially in young children, where it causes very, very devastating disease. In hospital-admitted children, where they present a severe febrile illness, sometimes confused for either severe falciparum malaria or some other, I would say, septic infection, or sepsis or septic infections. These are fairly non-specific symptoms that you see. In nearly half of the cases, you sometimes even see respiratory symptoms. And I would say the mortality rate is extremely high unless there is some very, very urgent attention to these children. Nearly a third of them will die within 48 hours. And through our studies in the last 10, 15 years, we've not been able to observe or find out zoonotic sources for this bacterium. But utilizing genomic analysis, what we found out is that these are strains that over time have shed off some genome, and they have evolved to be typhoid-like. In other words, to be human adapted, anthropogenic, meaning that they are transmitted almost human to human, just like typhoid would do. Unfortunately, again, the WHO syndromic guidelines for treatment predicts only about 6% of these infections. In Africa, particularly, we have challenges of lab confirmation of this disease. We don't have RDTs that are specific for this infection. It's a big challenge, leading to, again, high levels of underdiagnosis or misdiagnosis, misuse of antibiotics, overuse of antibiotics because you're treating empirically. So that, again, has been a major contribution for drug resistance in this enteric pathogen. And what we've found out, particularly in countries where surveillance is active for invasive non-typhoidal salmonella, is this constant cycle of infections going between East Africa and Central Africa. And then now, as you find through the last decade or so, a lot of new cases also emerging from West Africa. We didn't see NTS before, where typhoid was more important than NTS. We find now NTS becoming extremely important. Again, key among these strains is the rising levels of MDR. Sometimes we even find XDR. And in a number of cases from DRC Congo, recently reporting pan-resistant strains, meaning that among all the available options of treatment, none might work in probably 1 to 4% of strains that we find there. So very worrying. And when we look at phylogenetic analysis, surprisingly, and this is a rather busy slide, but I'm trying to explain this so that you understand what we're trying to do here. We're trying to understand in a case control study if there are differences between strains of INTS we isolate from cases, and this depicted in red or orange, as we can see here, versus carriers in the same households who are depicted here in blue. And what we found out actually is that within households, you will find a child that has just been discharged from hospital, having been treated with invasive disease, living alongside another child who is shedding the same bacterium, but apparently well. So there must be a key trigger that informs the move from carriage to invasive disease. And we think sometimes shedding within households can form a basis or a reservoir for both household, but also community outbreaks of invasive disease. And more recently, we've also discovered through studies on genomics for INTS, the fact that this same carriage can happen over long, long periods of time. And we're finding this is also driven by drug resistance over time. The more drug-resistant pathogens we're finding on INTS, the longer they are in shedding in apparently healthy children. That is sort of the key message here. The other bug that I wanted to give also as an example here is typhoid fever. Again, a disease that is endemic in Africa, in many regions of Africa. And of note again is the fact that we have a specific clade that is driving epidemics in the region. And this is haplotype 58 that really had its origins in Southeast Asia and spread to Africa, and over time has now persisted as the main clade that is driving epidemics. Again, looking at the importance of antimicrobial resistance in driving the epidemic, but also persistence of phenotypes that are multi-drug resistance. Our PhD student, Peter, has been carrying out studies following up children who have been admitted and then discharged home, and then also looking at siblings in a case control study and trying to understand carriage and shedding over periods of time. And what I was able to find out is that 1 out of 4 contacts that were shedding over periods of time between 2 months and 8 months, majority of them, minority of them, 1 out of 4, had gallstones. And these were either mature children between age 5 and 15, and also some of the adults that were actually forming part and parcel of the reservoirs in the households. And what we also found out in a study also by another PhD student, Susan, is that whereas 5 years ago, 10 years ago, we would have said for young children in Kenya and the region, INTS is a main problem causing invasive disease, we increasingly finding that multi-drug resistant typhoid fever is also being found in younger children. In these graphs, what we're finding is that there's a peak for very high occurrence of typhoid fever for children below 7 years of age, as you can see here. And you find most of these genotypes are the ones that are also forming the main epidemic in Southeast Asia. Of course, we have some lineages that are very specific to the region. As you can see in panel B, for example, we have lineage East Africa 1, East Africa 2, and 3. These are fairly important for just the region here. But overall, haplotype 58 is a major driver for epidemic multi-drug resistant strains of Salmonella typhi. In general, we find carriage rates between 5 and 10, depending on age and long-term shedding, even among children. And when we look at the hotspots where we're finding these cases, currently we find the same areas around our DSS site seem to be hotspots for both typhoid, but also for INTS, which means then definitely there is something in common in terms of reservoirs. There's something in common in terms of transmission routes for these two diseases, and also definitely some of the other predisposing factors for these diseases. And again, antimicrobial resistance is not just restricted to pathogenic bacteria in patients. You find even wastewater is a big problem in terms of reservoirs for antimicrobial resistance. And this is a study that also was done by one of our other PhD students, Rael, who graduated 2 years ago. And she was looking at wastewater high burden of carbon permanence producing enterobacteries. And what we found out here is that we have healthcare-associated bacteria that could be found in these waters, especially in raw sewage. And in some circumstances, sometimes you find these bacteria quite common, even in public places where we have open sewer systems before joining the municipal disposal sewer systems. And just tells you that there's a lot of these genes that are also, of course, combining, and also exchanging the genetic materials among the various enterobacterials that you find in the environment. And again, because we really looking at One Health approach, we cannot really discuss that until we also look at use of antimicrobials and resistance in livestock. And again, just to give a perspective of this, is that very little attention previously has been given to use or misuse of antimicrobials in agriculture in the country. It was always assumed that in agriculture, very little is used for growth promotion until you go out and look out and know that there's a lot happening with farmers. And this is really a slide that just gives you a picture of some of the importation that happens for purposes of livestock. And now, in this country and also in the region, what you find documented probably presents less than 50% of the total volumes that are used, because in a lot of cases, there is a lot of undocumented pharmaceuticals that come through the borders, especially for livestock. And we think this also is a major driver for resistance, and also including importation through these routes for substandard products that nobody really is aware about. And sometimes, as we say, the more antibiotics you use, the more resistance you see. And this is really a profile of resistance for chickens, fecal samples from just around the city. You see very high levels of resistance to some of the commonly used antimicrobials, and the same molecules that you find, of course, in use in our healthcare settings. So a very worrying trend, especially because we always assume in low and middle income countries, use of antimicrobials in livestock is minimal. It is not minimal. And yes, having spoken about the problems we have, of course, it's important to recall that through the WHO and I would say quadripartite efforts, we've been able to implement the National Action Plan to combat antimicrobial resistance over the last, I would say, nearly 8 years or so. And we have made substantial progress, I would say, but still a lot of effort that needs to go into strengthening governance, being able to look at priority activities that we need to advocate for, monitoring and evaluation of some of the things that we need to do among the key objectives. And even as we revise the National Action Plan in phase 2 to look at more sustainable ways of preventing and controlling AMR, we need to implement prioritized activities, and we need to mobilize domestic funding to be sustainable. And one of the things, one of the factors that we've discussed locally as One Health teams that drive the fight against AMR is utilization of IPC, infection prevention and control, as, as an important measure for preventing misuse of antimicrobials and, of course, being able to protect variable antimicrobials. Of course, in the farms, biosecurity plays a key role in ensuring that we don't have necessary outbreaks of diseases affecting animals. And there are various studies done both in the US and Europe that clearly indicate that if you are able to invest in IPC and hand hygiene, you can reap dividends in terms of reducing the number of infections you see in hospital settings, avoiding deaths, but also the economic gain because you are able to save money from buying antimicrobials. So looking then at antimicrobial resistant pathogens as a big problem in Africa, particularly, what opportunities lend themselves in the integrated One Health approaches? What we see is that sometimes you see excessive use, but sometimes also lack of access to life-saving antimicrobials in health, in human health, but also in livestock. We find diagnostic stewardship and antimicrobial stewardship is a big challenge. Again, especially in implementation, in providing resources that could mean having a sustainable process in ensuring that these are implemented. We have not yet been able to look into data that defines the role of environment and its contamination and how that plays in terms of preservation of AMR as reservoirs, but also dissemination and transmission to vulnerable populations. We know that vaccines are important because they prevent diseases from occurring in the first place, and will be a good mitigation against antimicrobial resistance. Again, have we been able to utilize this as a tool? Not optimally, in our opinion. We've used public awareness and education on a continuous basis, but again, are we hitting the right chord? Are we speaking to the right channels? Are we really doing it right? And as we know, of course, there needs to be a renewed effort towards R&D pipeline for new antimicrobials. And hopefully AI, machine learning would help us facilitate this process. There are policy changes, policy and regulatory issues that are a huge challenge in our settings. You find, of course, we have all the laws that have been written, very well done, and regulations, but the implementation part of it is really the biggest test because we probably, again, lack the capacity for imposing or being able to implement some of these policies. But in my own opinion and that of my team, again, selling the issue of how best we can fight antimicrobials has been a big test for us. Policy makers understand shillings and cents in our case, or dollars in other cases. Being able to package the problem of AMR in terms of how much you can save if we implement national action plans, if we are able to save antimicrobials that are currently useful or effective, how much can we gain as a nation that can turn around the economy as we know it. That message needs to come out to policymakers for them to be able to know that by investing in fight against AMR, they are investing in a future for the population, but also economic gain. And of course, lastly, it's very, very important that we look at global collaborations and partnerships, such as what we have done with UCSF, looking at commitments of the Global South to ensure sustainable approaches in terms of how best we are able to do surveillance, because data informs action. Without data, we cannot even speak to policymakers. And that we cannot do unless we work together with others. Let me end by acknowledging our partners. This is, as I said, work that has been done through collaborations and partnerships at DNDi, Cambridge, Ohio State University, Emory, our colleagues, and also with funding from Wellcome Trust. So I'll stop there, and really looking forward to a discussion on some of this presentation. Thank you.
Thank you so much, Dr. Kariuki. That was an amazing overview of AMR in the African context. And actually, having grown up in India, I know it's a big issue in India as well for very similar reasons. I'm not a clinician, but I noted something and I wanted to get us started with the Q&A with a question that I have. I saw that there were many cases with gallbladder and a connection between typhoid and cases with gallbladder. So I'm just curious if you can just elaborate on that a little bit. What's the connection?
Yes, yeah, that's an important observation. What we found out, and biologically, what typhoid does is to hide within the gallbladder, especially around gallstones, and they hide there by having biofilms around them. And then, of course, for the carrier, they don't suffer disease because they live harmoniously with the bacterium. And problem is that, of course, they shed these bacteria, which then, of course, can affect vulnerable individuals around them. So in every population, you'll find about 2 to 3% of a normal population with who are carriers or shedders of typhoid bacteria, usually because they form these biofilms around the gallstones. Now, the solution for that is usually surgical to remove the stones and then treat the individual. But in the meantime, if they're not discovered in the population, they continue to be a source of infection.
Okay, great. Thank you. Had no idea. I'd like to open it up for questions for Dr. Kariuki. You can unmute yourselves or put your questions in chat. Um, Maybe unmute yourself and ask the question.
Good evening. Thank you so much for the presentation. I really enjoyed it, even though I was driving. It was a great overview, as Purva said. I wanted to ask about the UN high-level meeting that was a year ago on AMR, and if that does indeed translate to what you're seeing in country and how important those UN high-level meetings are. And thank you again.
Thank you very much, Andrea, for that comment. Yes, as you know, high-level meetings at least are able to drive some action in terms of policy. We do the work, we provide the data, But at that very high level, then they're able to articulate, utilizing the data that we produce, to be able to highlight the problem of antimicrobial resistance at a global level, hoping that that then translates into policy at the state level or national level, and then action can then start from there. So I would say, politically speaking, that was a very, very important forum, because it provides really a high level data curation of what the burden of AMR is globally, but also pointing out some of the regional differences and the regional peculiarities that need attention. Because like in Africa, we have a huge burden, yet, of course, we have very few options available for treatment that are effective. So that kind of paradigm requires special attention for us.
Great, thank you. Any other questions for Dr. Kariuki? Feel free to unmute yourself and ask.
Hi, Dr. Kariuki. This is Dilys Walker. I'm a maternal child health person, and really, once again, would like to thank you for an excellent presentation. You spent quite a bit of time on the cholera, non-typhoid salmonella. I'm curious whether there are any bugs, microbes out there that you think are going to be the next frontier of where we really need to focus in terms of developing resistance. Thank you.
That is an excellent question. Yes, these are bugs that we study because we've seen them causing a lot of suffering in young children, but by no means are they the only ones. I know for sure we've seen also antimicrobial resistance in Shigella, because Shigella is also another pathogen that is of importance in our region. For us here, the main species is Shigella flexneri, very, very important for us. In hospital or healthcare associated infections, Acinetobacter is a huge, huge problem in our settings, Klebsiella, as well as E. coli, both in UTIs, but also sometimes in bacteremias. So these are some of the bugs that we see that are really problematic when it comes to human health around our settings. Let me say that there are great efforts in advancing possible candidates for vaccines in some of these. Recently, we have had phase 2 trials for INTS vaccines. We hopefully will get into phase 3. We also have some vaccine also for Shigella coming through. So there is hope, but that again will take time. But in the meantime, we need to look for ways to preserve those antimicrobials that are still working. Thank you.
Thank you. Any other questions? Okay, I have one more question, Dr. Kariuki. Since the livestock industry, the use of antibiotics in the livestock industry is quite prevalent and is leading to some of the resistance that you see, I'm wondering, what is the government doing to kind of oversee and raise awareness and educate people in that industry to not use as much antibiotics?
Yeah, an excellent question. And again, we have the Interagency Antimicrobial Stewardship Committee that has been tasked with ensuring that the message of awareness, creation, and education goes across the different sectors. So that's one channel, and we've tried to utilize this even in our studies in government circles, also through the Ministry of Livestock and Agriculture as well. But we need more of it to go out. We feel that, yes, the government attempts to do civic education in as far as first and foremost biosecurity for farming areas, ensuring that livestock also farmers have access to vaccines as well. That is something that's very, very good. It's happening, but we need more information to go out there, particularly on prudent use of antimicrobials. And this is because, for example, in the veterinary profession, we have very few of them that are qualified to dispense antimicrobials. And majority of them are concentrated around the areas around major towns. And we have rural areas where there's a lot of farming, like in the Maasai communities and so forth. Unless an area is lucrative, very few vets will venture into that area. So these are some of the gaps that we find. So those kind of areas then have paravets and sometimes even the farmers themselves. So rather than restrict this information about prescribing and use of antimicrobials to only professionals, we need now to reach out to paravets, to even the farmers themselves. If they're going to use antimicrobials, what message do we give them? How do we best help them to determine what is important for the animals before they use it? Because use it, they will actually buy them, regardless of what we say. But we need to educate them to be able to realize that the more they use it or misuse it, the more the animals will probably have issues on health later on.
Yes, exactly. Thank you. There's a question here in chat. Feel free to unmute yourself, introduce yourself, and ask your question. Xiaomi? Um, okay. The One Health approach emphasizes the interconnectedness of the environment, veterinary, and human health. Does this study include efforts to integrate these dimensions, or are there plans for collaboration in this regard? My background is primarily in human health with a focus on public and clinical health.
Thank you for that question. Again, a pertinent one regarding our efforts in addressing antimicrobial resistance from a One Health perspective. We try as much as possible. And Robert Onsare, my colleague here, is actually director of the One Health program at Cambridge. And what we do is, for example, in Mukuru, when we're doing work on patients or patient materials or patient samples, we're also looking at the environment as well, because that component is such an important one. Because humans in the home, in the communities interact all the time with the environment, and then if they have any animals, then we also work towards understanding their interaction and possible transmission across the different ecosystems. So that attempt has been happening. It may not have come out in a very elaborate way because of the fact that it's limited in slides, but we do that attempt all the time. Hopefully, some of our publications that you could Google out from Cambridge will clearly articulate that. And even the ministries of health and ministries of agriculture and livestock and environment clearly also emphasize the need for that One Health approach. At least from that policy level, there has been acceptance that all these sectors must work together. And that was a big win for the fight against AMR in the first place. Yeah.
Thank you. Any other final questions? We just have a few more minutes left.
Yes, Purba,
Yes.
can I?
Yes, of course.
Yeah.
Please introduce yourself.
Thanks. Yes, so my name is Robert Onsara. I work with Prof. Kariuki. So thanks, Sam, for that great talk, great insights from really very informative data. So we're very grateful and happy that you're able to share with us this. Now, I have a question regarding the application of One Health there have been, as you may aware, here in Kenya, there have been efforts in terms of trying to introduce One Health, topic in academic institutions, postgraduate trainings. Do you think that we could do more than that? I attended a meeting in Asia where they have actually taken it a step higher. They actually taking primary school children to to the real areas where One Health is One Health negative effects, like where they are flooding, so that they carry out lessons. Really, they carry out their lessons in some of those regions. Do you think more should be done other than just introducing, of course, which is commendable, introducing One Health modules in our education system? Thanks.
Absolutely, Robert. I can't agree more. And the One Health concept, just like primary health education, needs to percolate through all the age groups. Let me give you an example. In our studies on cholera in this informal settlement, our social science staff were doing interviews with school children aged between 6 and 15. And the moment you give information regarding how they should handle water in the house, how they should not take antibiotics without prescription, the next morning and the next 3 days, parents will come to the clinic complaining, what did you tell our children? We can't even give them medicine. What's happening here? I mean, it's the power of how children can relay information. And if taken positively, of course, by having engagement with the parents in the first place and the communities, that's a very powerful tool, right from when they're young. So I can't agree more. Thanks.
Thanks, Sam.
That's a great point. All right. Well, we're pretty much out of time here. If there's no final burning question, I think uh, I would like to convey my sincere gratitude to Prof for an excellent overview of AMR in Africa and this really engaging discussion, and for launching this new Global Partner Spotlight series that we've begun. So this was the inaugural talk, and thank you. I know it's late for you, so thank you again, and thank you to everyone for making the time to attend.
Thank you for